All right, everybody. We'll get started here. I think I know most of you here, but if you don't know me, I'm John Rice. I'm the Section Chief for Hepatology. And it's my pleasure to introduce Dr. Keith Lindor to give the Department of Medicine grand rounds today. It took me about an hour to get through Dr. Lindor's CV last night, so he's quite accomplished. But a few highlights for you here. Dr. Lindor did his undergraduate work at the University of Minnesota, where he received a Bachelor of Science in Chemistry. He then went on to Mayo Medical School for his medical degree. He completed his residency at Wake Forest University, and then returned to the Mayo Clinic to begin what has been an illustrious academic career. His primary focus has been both in the cholestatic liver diseases, primary biliary cholangitis and primary sclerosing cholangitis. And there's probably no scientist in the field who has advanced the knowledge of both of these diseases as much as Dr. Lindor has. More recently, he's been more involved with non-alcoholic steatohepatitis as well. His academic career has been truly remarkable. I was looking through his CV, and his first publication was in JAMA. So in addition to that, he's published over 300 manuscripts, the majority of which as first or senior author. In 1996, he was named a professor of medicine at the Mayo Clinic. And in 1999, he began his tenure as the chair of the Division of Gastroenterology and Hepatology, a position he held until 2005, when he was named Dean of the Medical School at Mayo Clinic. He continued to serve as Dean until 2012, when he moved on to Arizona State University, where he began serving as the Executive Vice Provost of Health Solutions, a position he held until 2015, and the Dean of the College of Health Solutions at Arizona State until July of 2017. Presently, he is serving as professor and senior advisor to the University Provost at Arizona State. In addition to all of the academic accomplishments noted above, he's also served as the editor of Hepatology, which is the premier journal in the field of hepatology, and served as the president of the American Association for the Study of Liver Diseases in 2016. So with that introduction, the title of Dr. Lindor's lecture today is Optimizing Management of Primary Biliary Cholangitis. Please join me in welcoming him to Department of Medicine Grand Rounds.
Well, I very much appreciate that nice introduction, John. Thank you. As John said, much of my work has been on trying to optimize the treatment of primary biliary cholangitis. Many of you might recognize this as a new term. It used to be called primary biliary cirrhosis. One of the steps we took in optimizing this was to change the name a couple of years ago. It took quite an effort. We had involvement from a variety of patient groups and most of the international societies supporting this. The reason for doing this was that the term cirrhosis, the patients told us, was a problem for them. Oftentimes it interfered with getting employed or getting insured. And in truth, most patients with PBC, we wanted to keep the acronym, didn't have cirrhosis. When the diagnosis was initially established many years ago, most patients were cirrhotic, but in recent years, just a minority have been. So this name change was one of the things that was done just a couple of years ago to try and help optimize this. Today I wanted to talk a little bit about the epidemiology, diagnosis, how we come about this, and then with a focus on treatment, both for the primary liver disease and some of the associated conditions that other of you in the Department of Medicine might come across. We've seen an increase in the prevalence of PBC in recent years. This shows this. It does two things, really. It shows the changes in women in the top blue bar and in men in the bottom bar. And you can see this is a disease primarily of women. It's about a 10-to-1 ratio typically. And in both cases, there's been a slight increase in prevalence in men, a much more pronounced one in women. Prevalence can increase either because people with the disease live longer, so there are more prevalent cases, or the incidence of the disease can increase. There can be more new cases coming in. And this is probably a combination of both. These are some older data that suggested that the incidence, the number of new cases per year, were increasing, particularly in women, not so much in men. Updated numbers now from last decade show that this trend has continued. So we don't really understand, we don't know first what the cause of PBC is. There may be some environmental factors that are important. If that's the case, that may in part explain this increasing incidence of the disease. So there are some particular spots. There's been some linkages to environmental, geographically defined environmental exposures that may be important, but in truth we don't really know what causes this or why this occurs. I think the other part of all of this is it's typically seen as a classic autoimmune disease, and we've seen, I think, as the bacterial load within foodstuff is diminished, an increase overall in autoimmune diseases broadly, and this may just be a reflection of that as well. One of the things that we've been particularly pleased about is our ability to diminish the need for transplantation. I've just shown you that the number of cases of PBC is increasing, but in the blue bar, or blue figures, you see that the number of transplants needed for this disease has decreased. And this, I think, is really a reflection of finally finding effective therapy. The red shows our futile efforts in PSC, which I spoke about last night, and how little progress we've made in having an impact on the need for transplantation life expectancy with PSC. But the blue shows the success that we've had in improving outcomes for PBC patients. This is a representative liver biopsy, which shows a fairly robust inflammatory response with lymphocytes surrounding the bile duct. This would be the classic picture for PBC, the so-called florid duct lesion. Sometimes pathologists are loath to make a diagnosis of PBC unless they see this, but in truth this is found in fewer than, this florid duct lesion is found in fewer than 10% of patients' liver biopsies with PBC. So if this lesion is required for the diagnosis, 90-some% of patients will be missed histologically. One of the other features about this is when we see this florid duct lesion, this oftentimes means an immunologically more active disease course. These patients tend to have a more aggressive disease, and some have suggested, although it's not been clearly demonstrated, that this might be a group of people who should be treated with immunosuppressive therapy as well as ursodeoxycholic acid, which we'll get to in just a minute. One of the other things that's happened is we've moved away from requiring liver biopsy for making the diagnosis. So the slide I just showed you, the exuberant response on biopsy, we don't see very often anymore because we seldom do a liver biopsy for PBC. The 2009 practice guidelines didn't require a biopsy, particularly if these criteria are met. If a patient has elevated alkaline phosphatase and their transaminases are less than 5-fold normal, and they're AMA positive, that's pretty much going to be PBC. Maybe once or twice out of 100 we might see now superimposed steatohepatitis, but we seldom, this is a pretty reliable set of criteria for establishing the diagnosis. The guidelines would recommend that we do certain things as far as surveillance for portal hypertension if cirrhosis is found on biopsy. But now that we don't do biopsies, we have had a harder time identifying cirrhosis. With FibroScan coming available in the last couple of years, that's now more often used. But this is a very simple way of trying to identify who's at risk of having portal hypertension and should be screened with upper endoscopy for varices. If the platelet count is low, high likelihood that that patient, about 7 or 8 times greater than if their platelet count was normal, has portal hypertension. You can use the more complicated Mayo risk score. That adds a little bit, but just I think a useful rule of thumb has been if the platelet count is low in a patient with PBC, they're prone to have portal hypertension and would be eligible for surveillance. I just mentioned the FibroScan. These are data showing results from FibroScan and cholestatic liver disease. This has been a useful sort of point-of-care way of trying to assess risk. Patients who have high values tend to have a poorer prognosis, more likely to have cirrhosis. I think we're still trying to feel our way about what the exact role of this test is going to be. It's been in the office now for about 2 years or so. So accumulating experiences in the U.S. is starting to give us some guidance as to how it might be most appropriately used and how decisions might be based on that. One of the, I mentioned earlier that those patients that have the more immunologically active liver lesion tend to have a more aggressive disease. This is looking at it if people have features that suggest an overlap with autoimmune hepatitis compared to just PBC. This group of patients tends to have a poorer outcome. Paradoxically, in PSC, primary sclerosing cholangitis, the opposite is true. We don't have a treatment for PSC, so those patients who have overlap actually do better because we can treat the autoimmune component. Some people believe that AMA is tantamount to having PBC, and that's probably not true. It's probably one of the best tests that we have immunoserologically. About 96% of patients with PBC will be AMA positive, and somewhere between 1/10 and 1/2 of 1% of normal people will have AMA positivity. So even though it's a really helpful diagnostic test, one of the conundrums comes when if people are screened for whatever reason and have an AMA, even with normal liver tests, most of the time that AMA is going to be a false positive. So we typically don't think of AMA as requiring treatment for PBC. And this shows how often patients with normal liver tests initially, just as basic AMA was done, the pace at which PBC eventually develops. There was an old paper from about 35 years ago that from a rheumatology clinic that suggested everyone who had AMA eventually developed PBC. But I think that was a selected group. This is patients who are drawn mostly from blood bank or more normal people, and their risk of developing PBC, even if they're AMA positive, is shown here and is quite low. This is a disease for which there are a lot of ideas about what might work. They're kind of grouped as now nuclear receptor targets, or looking at things on the membrane. Oftentimes when a list is long like this, it's sort of indicative of us not really knowing the cause of the disease. Although that's not always true. For hepatitis C, for instance, you're aware of the baffling array of direct-acting antiviral agents and their combinations. We know exactly what causes that, but right now there are a variety of different treatments for it. Ursodeoxycholic acid still is the mainstay of treatment for patients with PBC. These were data from 3 combined series which were used to gain FDA approval for this, and it shows an improvement in survival free of transplant with people receiving urso from the outset. The comparator, 2 of the studies switched over after 2 years from placebo to urso. The 3rd study kept people on placebo for up to 4 years. So if this were truly a true placebo group on the bottom, the impact would be even greater. You can see here that patients with PBC who are treated do better than would be expected based on the Mayo model in the panel on the left, and they do slightly less well than a general French population. But this is a group, this has gone from PBC, the leading indication from liver transplantation 30 years ago, to now relatively uncommon and almost having a natural history that matches the general population. Here, this is looking now at when treatment is started. So patients who are started before they become cirrhotic on ursodeoxycholic acid do have a life expectancy just the same as a general population. Whereas if patients are wait until they become cirrhotic and then be placed on ursodeoxycholic acid, their outcome is better than if they weren't treated, but it's not nearly as good as the general population. So this is one of the reasons we've advocated looking for the disease and getting patients on treatment early enough when you can give them a life expectancy that's essentially normal. Ursodeoxycholic acid also looks to be effective after transplantation for PBC. The cholestatic liver diseases recur after transplantation at a rate of about 3 to 4% per year. So not a lot, not like viral hepatitis used to be, but still enough to be worried about. And some of these people now are starting to come to need retransplantation. So ursodeoxycholic acid post-transplant helps prevent recurrent PBC also. Well, oftentimes urso isn't ursodiol isn't enough. About a third of patients will eventually achieve complete biochemical normalization. That group of patients does really well. That means about 2/3 of patients still have elevated levels. We've looked at, I'll show you in a moment, different ways of trying to assess responsiveness, and then following that, a bunch of the treatments that have been proposed. This was a look at, these are data from Mayo with at least a year of urso treatment, and looking at when clinical events occurred. So patients who had values that were of alkaline phosphatase twice normal or higher had a 2 to 3 times greater risk of developing serious adverse clinical events compared to those with lower values. Obeticholic acid uses a cutoff for treatment of 1.67, but it really looks like anything less than 2 is probably going to protect people from other adverse clinical consequences. So there's some, I think there's a table coming up next that will show you various cutoffs that are used. This is shown here. One time we went to the FDA to talk to them about obeticholic acid, and the word that came back in the letter from the FDA is the investigators don't know what they're talking about. I sort of took that personally, but what they were discussing was this, and so you can see that there are at least 6 different systems that are used to assess adequacy response to ursodeoxycholic acid. Pretty much all of them use alkaline phosphatase at various cutoff levels, but in their eyes, because of the lack of the consistency, the investigative group didn't know what they were doing. Eventually, of course, the drug got approved. This is what obeticholic acid did in the clinical trial. This is looking at changes in alkaline phosphatase. And what this, initially the first study was done with 10, 25, and 50 milligrams, and the 2 higher doses were about as efficacious as the 10 milligram, but caused a lot of problems with itching, and a number of patients had to be withdrawn. So the next study was done with 5 milligrams, and the possibility of taper up to 10, and that's what this shows here. And it shows the reduction in alkaline phosphatase level with the 2 active compared to the placebo treatment. This is conjectural, but this is modeling to suggest what effect overall on survival or obeticholic acid may have. There's a long-term treatment trial now looking at clinical endpoints for patients with PBC. One of the 2 or 3 weeks ago, there was a memo that came out from the FDA warning that there had been about 30 patients treated with who had PBC treated with obeticholic acid who had died, and part of that was people did not. And it was in the 5th paragraph in the package insert, so sort of hidden, that for patients with more advanced disease, there would need to be a dose reduction. So this is a lot of consternation about this, the role of the drug, particularly with patients with advanced disease. One of the reasons there was a push for that was for the FDA long-term extension. They wanted to know what the clinical impact was, and that study population was enriched for patients with more advanced disease because it was clinical endpoints that were being sought, and over a 5-year period, if patients start with early disease, as I showed you, there's very little likely to happen. And so it's been an interesting interplay that we're working through right now. One of the challenges with obeticholic acid is the cost. ICER, which is the Institute for Clinical and Economic Research, did this. It's a carefully done study looking at information about the impact on obeticholic acid on life expectancy. This is typically added to ursodeoxycholic acid, so it's an adjunct in the suboptimal responders, and this is what they looked at. And so what they found was that a quality-adjusted life year cost was really pretty high. But usually we look for somewhere $50,000 to $100,000 would be many times what's acceptable. So $370,000 was pretty expensive at the current cost. Hopefully the cost will come down, but right now that's the situation. So sometimes it's a challenge to get insurance companies agree to pay for this when they have data like this in front of them. A lot of treatments are being considered. Again, I mentioned before that you could break them down into class. We've been fortunate in both PBC and PSC to have a lot of interest in new therapies. Probably the best thing that happened to this field is the effectiveness of the direct-acting antiviral agents for hepatitis C. Sort of paradoxical, but companies and investigators who were focused on hepatitis C now have looked for other therapeutic targets for products that they have in the pipeline. So remember, hepatitis C, single pill a day, 98%, 96% cure rate over several weeks with very few side effects. And so that field has changed dramatically because of that. And what we've seen is a lot of companies who were in that hepatitis C area shifting focus, and that's what we see here is just we're the beneficiaries of that change in attention. So these were new drugs, many under development. I'll show you examples of the results from a couple of these, but also wanted to go back to an old drug. So we have the fibrates have been around for a long time. In the United States, we have fenofibrate, and in Europe and Japan, they have bezafibrate. We don't have bezafibrate here, but the results for both fenofibrate and bezafibrate are relatively similar. This shows, in a recent paper, the effect of bezafibrate. And I think what is impressive is the degree of improvement. So I showed you the obeticholic acid, about a 25% reduction in alkaline phosphatase. Some of these people have much more dramatic. But here, this is looking at the effect on itching. So a visual analog scale is just sort of that line you draw and mark how bad your itching is. A pretty simple way of doing it. But this had a dramatic effect on itching. Contrast this with obeticholic acid, which has a risk of increasing itching. This is generic, or fenofibrate in the U.S. is generic, and so it's really probably pennies a day, dollars a day compared to very expensive medication. And so this is an area of active exploration, but these results on itching have been, I think, impressive. This is looking at another drug, one of the new drugs, and what this has shown is a fairly dramatic improvement in alkaline phosphatase. A number of these patients had normalization of alkaline phosphatase, which we don't see very often over a short course. As I mentioned, ursodeoxycholic acid leads to normalization in about a third, but it takes 5 years to do that. Within 2 years, about 20% of people normalize. So some of these drugs show quite a bit of improvement. This drug was interesting in that at higher doses, it was like what I mentioned with obeticholic acid. There was an increase in liver toxicity. Initial 20 patients, 4 patients had a very bad drug-induced hepatotoxicity, but with lower doses, that hasn't been seen. So this is something to keep an eye on. And then there's another drug that interferes with bile acid metabolism, FGF19. And this, too, has had, I think, really fairly impressive improvement in biochemistries without exacerbating itching. So there are a number of drugs at which we're starting now to get very early but encouraging preliminary data from clinical trials that might change the landscape of how we treat PBC in the future. I want to turn away from treating the disease itself to some of the other factors that can complicate the management of these patients. It took a number of years before it was clear that liver cell cancer was increased risk. I remember textbooks years ago would say people with Wilson disease and PBC seem to be free of an increased risk of hepatocellular cancer, but it turns out that wasn't the case. But it's not that common. In a series in 2,500 patients that had been followed over a 25-year period, we found only 17 cancers. So not like a cirrhotic viral hepatitis patient are probably your cirrhotic alcoholics here, where the risk of liver cell cancer is 2 to 3% per year. For PBC, all comers, and again, many of these were cirrhotic. The risk is increased over baseline, but not nearly as great as we used to think about for some of the other conditions. At one time, there was a paper that suggested that people with PBC had a similar risk of developing liver cancer as patients with chronic viral hepatitis, but that didn't turn out to be the case and really allowed us to modify recommendations about surveillance. So now that we've really focused surveillance just on patients who meet these criteria. Of course, with cancer, older patients are always more apt to get it, but it's again, men, and I'll show you a little more data about this and showed you the data last night for PSC. In portal hypertension, so men with advanced liver disease are really the ones who are most prone to develop HCC and are the ones that should undergo regular surveillance. This is looking at the gender distribution of liver cell cancers in patients with PBC. So even though PBC is 90% of the time in women, the cancer risk is substantially higher in men, as shown here. And then this is just another group now confirming what we had shown, that the disease severity seems to be an important driver. So patients with more advanced disease, portal hypertension in particular, are those that are at increased risk of developing liver cancer. So from the standpoint of targets for surveillance, these would be the patients that we would think we should target. And one of the questions anytime we suggest surveillance is, does it do any good? And these are data that show that patients who had PBC and developed HCCs, if they were discovered via surveillance, shown in the dashed line above, had a better outcome than those patients who just developed the incident cancers and presented with symptoms. So this has been part of the impetus for us to recommend that patients with PBC undergo regular surveillance if they have, particularly if they're men and have advanced disease. Usually ultrasound is fine. Many of these were ultrasound at 6 to 12-month intervals. One of the biggest symptomatic issues for patients with PBC is fatigue. And if people are disabled with PBC, 80% of the time it's due to fatigue. We don't really know why people have fatigue. There are data from Newcastle that suggests there may be cardiovascular issues that do this, but the etiology has been fairly unclear. Mark Swain in Calgary looks at neurotropin abnormalities, but that can show that in mice, but that hasn't really turned out to be relevant or pertinent in humans so far. Initially, we had done studies with antidepressants, Prozac, randomized trial. That really didn't do any good. This isn't untreated hypothyroidism. There doesn't seem to be an obvious cause. Modafinil, Provigil, Nuvigil, see it on the billboard sometimes for shift disorder or nighttime sleepiness. It's sort of a stimulant. Initially, the pilot study from Newcastle suggested that this might be effective, but a randomized trial, which we did, which was just published, suggested that compared to placebo, it really wasn't advantageous. So these studies, particularly itching and fatigue, really do require a placebo control, because oftentimes without that, you might be led astray. So patients don't want to have these symptoms. Oftentimes they're agreeable, and without the placebo group, you can make a false conclusion that the drug was effective. This had happened with modafinil some time ago. This is looking at another group of drugs, another newer drug, and looking at the effect on itching, and showing that itching, in this case, itching was oftentimes improved compared to placebo, but you can see the size of the placebo effect in the middle bar, and then after the drug was stopped, sort of the rebound in symptoms. So, interesting area, complicated. There's a new pathway, lysophosphatidic acid, autotaxin, which has yet to really be explored pharmacologically, but that seems to be potentially an important pathway for the pruritus of cholestasis. One of the other problems that these patients can develop is bone disease. They can develop a metabolic bone disease due to their cholestasis. These patients tend to not have problems with too much vitamin D deficiency. You might think because of the conversion of vitamin D in the liver that that conversion, hydroxylation, may not occur. That's not been much of an issue. But people who have advanced cholestasis tend to develop the fat-soluble vitamin deficiencies just due to malabsorption. So vitamin D, the recommendations now are almost universal to use it anyway. So these patients frequently get calcium and vitamin D, but that doesn't always do the job. So there's been a lot of exploration of some of the bisphosphonates in particular. We've shown estrogens were fine, raloxifene was fine, but that the treatment for osteoporosis has moved away from estrogen therapy into bisphosphonates. This shows the increase, the likelihood of developing by age of osteoporosis in patients who have cholestasis compared to age-matched controls. And you can see that in PBC, it always looks like there's somewhat of an increased risk. Some series will have substantially greater risks compared to the general population. You can also see in the white bar that the aging population, as we know, tends to have more osteoporosis. But PBC exacerbates that. A study that we did a number of years ago compared one of the bisphosphonates, alendronate, to placebo and showed this to be superior. We were always a little bit worried about that because of some of the esophageal irritation that we saw with that. Another study now is looked at abandronate given once a month compared to alendronate given once a week, and really pretty comparable as far as efficacy. Most of the fractures when they occur are vertebral fractures, so looking at the spine, which this does, is the particularly germane body part to study. So the two are comparable. This is looking at the hip, and if anything, it looked like abandronate maybe had a little bit of an advantage. So it's certainly more convenient, and maybe these are the first data moving beyond alendronate. We'd studied etidronate, which isn't used anymore, and that was not potent enough to be effective. The other set of problems that patients with cholestasis and PBC can deal with has to do with cardiovascular disease. These patients oftentimes have very high cholesterol levels. You can see that some of the old pictures with xanthelasma. I've seen patients who've had tendinous xanthomas that are so bad they can't really close their hand. Ursodeoxycholic acid mobilizes those lipids. So in the last dozen years or so, we've just virtually seen none of those problems. But still patients may have high cholesterol levels, although again, ursodeoxycholic acid will lower LDL cholesterol levels in patients with PBC. But because of the high cholesterol levels, there's been concern about increased risk of cardiovascular disease. And this shows that regardless of what's looked at so far, there's not been significant increased risk, although some of these start to edge up towards that. I think that much of these data were collected when we were worried about statins in patients with liver disease. Now, just this week, a paper came out that suggested that statins should be used therapeutically in patients with liver disease, particularly fatty liver disease. So the pendulum has swung a long ways from can't use statins in patients with liver disease to now thinking it should be something that's more standardly used. Sort of reminds me of the role of beta blockers. You can't use beta blockers if you have congestive heart failure. Now you're reprimanded if you're not using beta blockers in patients with heart failure. So this is, again, one of those sort of wild swings. But I think one of the things we've also seen is that with increasing risks of metabolic syndrome, obesity, patients with PBC are not necessarily immune to this. And so we don't want to not treat people who should be treated, who would be at cardiovascular risk, family history, smoking, diabetes, or high LDL levels. We don't want to not treat them by relying on the statement that patients with PBC don't have increased risk. I think a lot of these studies were done, data were collected before obesity became such an issue here. I think the other part that we think is that sometimes lipoprotein X, which is a pretty avid binder of cholesterol, is increased in patients with cholestasis. And I think maybe what happens is that lipoprotein X, which is increased in the circulation, holds cholesterol. So when we measure cholesterol, we're looking at, in these patients, a pretty high contribution from lipoprotein X, which isn't cholesterol there is not atherogenic. It's just probably held in the circulation. That may explain the paradox between high levels of cholesterol when we measure in the serum and a less than expected risk of cardiovascular problems. So, what can I tell you about PBC before I open up for questions? This is a disease that's becoming more common. We don't understand why, but I think many of you will be faced with it. It's a disease, if we can recognize, and the diagnosis is relatively easy, no longer requires liver biopsy, and institute therapy earlier, the outcome for patients will be better than if we wait for a patient to suffer from the disease for a long time and make a diagnosis late. There are a number of things that we can use to help identify prognosis. I haven't talked about some of those. I've shown you the liver biopsy that showed the increased immunologic response. The same is true if we look at autoantibody profiles. Patients with various anti-nuclear antibodies, if they're positive, have a more aggressive disease than if they are missing those autoantibodies. And even patients who have fatigue have a poorer outcome, a poorer prognosis than those without. So between heightened immunologic response, whether assessed immunoserologically or by biopsy, or fatigue, these patients will have a poorer outcome. The FibroScan can also help you when you're seeing the patient for diagnosis. Ursodeoxycholic acid improves the natural history. There's a conjecture that obeticholic acid will. We don't yet have enough data about bezafibrate, fenofibrate to be confident, but particularly looking at the Japanese data that's accumulating with bezafibrate, we may be in a few years able to say this has an important impact on clinical outcome. Remember the cancer risk. It's not nearly as high as in PSC, but there is that cancer risk. We now have data that surveillance for selected populations will be helpful as far as prolonging life expectancy. So men, patients with advanced disease should undergo surveillance. And we have obeticholic acid, which was recently approved just a little over a year ago, and other products are in the pipeline. So dynamic field, a lot going on. And happy to have had a chance to talk to you about it this morning. So open for any questions you might have. Okay, John.
In the cancer risk, one of the questions I think we sometimes see with this is that people can have more than one liver disease, particularly if you can imagine some frequently comorbid NASH and alcohol liver disease.
Right.
In that data that shows the heightened cancer risk in men with PBC, was there any control for BMI, comorbidities, alcohol use, or other things that might have contributed to the development of advanced liver disease?
So I think at least the one series that I showed was a Mayo series, and those patients would have been, we would have tried to exclude those other concomitant diseases, but when you think of a series that extended back 25 years, 25 years ago we couldn't make the diagnosis of hepatitis C. You know, the testing only became available in 1989. So some of these patients could have had hepatitis C, but they would have been considered having non-A, non-B if they had active disease. So this should be a fairly pure population. I think that the obesity epidemic is really clouding the issue. That's going to become increasingly important cause of liver cell cancers. We're starting to see that. The reports come out about that now. So newer series will really have to be very careful about controlling for confounders such as that.
So, and doing this with the increase in women, have you seen if it correlates with other secular trends like increases in oral contraceptives, later pregnancies, anything like that?
There was a large epidemiologic study that Eric Gershwin did. We were part of that a number of years ago, and they tried to link this with cosmetics like nail polish. and hairspray, and there's some fluorinated hydrocarbons that linked, and there may be some cross-reactivity with the target antigen, which he's carefully defined. The other has been urinary tract infections, which are more common in women, so that has been implicated. Smoking has been implicated, but none of these have really fallen out. And I don't think the GWAS studies, genome-wide association studies, have clearly given us an answer either. It may be they're mostly MHC link, HLA links that we would that pop out of that. So there had been discussion in Sheffield, England about a water supply. In New York City, data about a Superfund. I used to see a lot of people from northern Michigan, Upper Peninsula Michigan with PBC. I tried to get people there to investigate that, but I think they had their hands full with some other problems in Michigan. So it wasn't, but I do think that there are likely to be, and it may be that there are many different environmental triggers. It may not all just be one single trigger.
I have a follow-up question on the epidemiology. May have missed this, but I think there's a perception and data from Europe that the vast liver disease leading to transplant has increased. Is that true in the U.S.? And if it is, why that may be occurring?
I think we've seen now in a couple of series a reduction in the need for liver transplant. I think this is the effect of having effective therapy. So the first studies about ursodiol were published in '88. We published our experience in '92. It took till '98 to get FDA approval for that. I think that there had been sort of, because the ursodiol available typically as Actigol for gallstone dissolution was available, I think people have been receiving this for quite a number of years, even 20 plus, maybe 25 years. And I think that's really what's influenced the need for transplant. We're seeing more cases. One of the challenges in thinking about a rising prevalence is maybe we're just better at case finding, and we're finding more cases early. And that could be playing a role. In Canada, they were able to track the rising incidence of PBC with migration of hepatologists. So when a hepatologist moved from Toronto or Montreal to one of these other provinces where they hadn't had one before, it looked like PBC came up. One of my friends in Rochester had been in Rochester, then went to Pittsburgh, and then moved to Arizona, and he was a hepatitis C expert. And he told me that when he got to Arizona, the State Department of Health investigated him because it looked like he was spreading hepatitis C. But it really was just people were being referred to him, and he was reporting it, and it looked that way. So I think that we're probably past that for PBC at this point, where I think there's pretty good recognition for it, although I sit on a group at Henry Ford, and looking at data from 14 million people with a population of 14 million, about 70% only of people with PBC are being treated as best they can ascertain. So there's still work to be done as far as identifying cases and getting cases that are identified on treatment. But I think in general, the decline in transplantation, even at a time when the numbers of transplants have risen, has been, I think, a measure of the effectiveness of therapy. So the question had to do with the AMA. Is it integral to the disease process, or is it a byproduct? Depends upon who you ask. So there's a group that really believes that this is the key, and they've carefully identified the epitope in the antigen that's recognized by the antimitochondrial antibody, and done a lot of manipulation with that. But AMA negative PBC is, for all intents and purposes, the same. And yesterday we talked about a case at the case conference who had autoimmune hepatitis but had a positive AMA, which we can see in a number of people. So I tend to be more on the side that is probably a bystander, sort of the way I think about anti-nuclear antibodies. If there's cell damage, their products are released and antibodies are formed. AMA is not quite so clear. There are several animal models of PBC. You can induce AMA, but the induced AMA doesn't necessarily lead to the liver disease. And you can induce a liver lesion that looks like PBC without causing antimitochondrial antibody formation. So I don't think we know for sure, but I think, in my opinion, the preponderance of evidence would be that it's more a byproduct of the inflammatory response rather than a direct target for the disease. Not so much. I mean, not a ton has been done about that, but it doesn't seem to be a mitochondrial disease. That doesn't seem to be the main target. Mm-hmm. The question was whether sleep disorders are part of the fatigue. To some extent, I think that they, of course, would play a role in people who have fatigue. But in general, this isn't a group of people who have much greater differences in sleep. So even though that's the most common symptom is fatigue, but sleep disorders, when studied, haven't been the explanation for most of the cases. It's been one of these things that may be multifactorial or may just be something that we're missing. But so far, if we had any one thing that would make patients happy with this after we changed the name, would be something for the fatigue.
Just a question,
Uh-huh.
follow-up question about antimitochondrial antibodies. Do you recommend that they be formed by immunofluorescence or by
They're mostly by ELISA now, the enzyme-linked immunosorbent assay. The other one, the immunofluorescence, can be done. I think that there are challenges. When I was a fellow, I was in the lab that did these things, and to get the kidney cells that they used for the substrate for the immunofluorescence there's always some question about how accurate they were, how valid they were, how often they had to change those out. This was one of the cases last night that was discussed. The report that they had from an outside hospital was in the units we use for ELISA, and it sounds like immunofluorescence is probably what's used here standardly. People have tried to come up with correlations. How does this titer match with this level? But there hasn't really been great correlations with that. So I think most of the time it's what's available. I don't know that it's worth, if you do immunofluorescence, to send it out for ELISA somewhere else. I think most of the reference labs, of course, use ELISA because it's probably easier to do with ship specimens.
We looked at this a handful of years ago, and obviously it's biased by the cases, but we looked at all of our positives, and over 95% of those positives were diagnosed with primary biliary cirrhosis. So, you make your diagnosis because you have the antibodies, and therefore you bias that type of an assessment. But at least in the lab at UW, it appears to be a very good test.
Which one were you using? Yeah. So for many years, that's what we used at Mayo, and then it moved into, at some point, maybe 10 years ago, to ELISA testing. I think either one is valid. And that was sort of, I think, one of the questions that came up last night. And the other thing is that the titer probably doesn't really have much influence on the course of the disease. So people can have very high titers or low titers, and still, if it's positive, it's usually positive. So there you go. If there are no other questions, thanks for your attention.